I'm happy to present this project, which has been carried out at the University of Bologna by a group of researchers with different backgrounds and coming from different departments and research labs. The overall idea is that try to deploy computer vision to improve the planning workflow in maxillofacial surgery. This is a branch of surgery that treats malformation of the craniofacial skeleton, like this one, that might be due to trauma or also other causes. Whatever the cause, the goal of the surgery is to reconstruct a regular, normal skeleton, which is called eumorphic. So, to plan the intervention, best plan the intervention, the surgeon will greatly benefit from a mesh, a 3D model like this, that would show him the eumorphic mesh, the eumorphic shape corresponding to these patients. But this obviously does not exist. So the idea behind this project is, why don't we try to design a computer vision system that, given as input a preoperative mesh like this one, would automatically output a plausible, specific to these patients, a eumorphic mesh, something like that. So, how to get to that? We took inspiration from a quite popular computer vision task, which is known as shape completion. Here, one is given a partial scan of an object and should reconstruct a whole scan of the very same object, with objects like chairs, lamps, and similar. Not surprisingly, the best machinery in this task nowadays are neural networks, which are trained with dataset of paired, partial, and complete shapes. So that was the inspiration. So we thought, okay, maybe we could design a neural network that would work as follows. Rather than asking the surgeon to, try to reconstruct this area where the malformation is, just ask him to, delineate the area where the malformation is. Then our computer vision system would automatically make empty space there, and then the neural network would reconstruct the whole shape. There's a difference, however, between the typical shape completion task and the task we are trying to apply to surgical planning. And the difference is that these neural networks that work for shape completion are trained on paired datasets. But for clinical practice, for a given preoperative mesh, we don't have the corresponding eumorphic shape. It does not exist. So we cannot use the standard training that is applied in the standard computer vision task. So how should we train our neural network to perform this task? What we could collect is a data set of eumorphic shapes. We collected one from a publicly, so it's a subset of a publicly available data set in which we extracted several, not that many, eumorphic meshes. Indeed, it is highly unbalanced because these whole skeletons, in which you see also the mandible, are really quite a few. Nonetheless, what do we have is a data set of eumorphic shapes only. Now, if you remember what I said previously, so our AI has not to see the malformation, it just has to see the empty space. So the idea was to randomly create empty regions out of these eumorphic meshes. And this creates arbitrarily many training samples for the neural network. Okay, these are some of the examples that we could create. So this is, and then the neural network is tasked with reconstructing a eumorphic shape for which we have a ground truth. This is quite a standard self-supervised training approach. Like, in a way, similar to what how large language models are today is pre-trained, with a reconstruction objective that masks out some of the data that you already have. Now, let's see whether this kind of work. So what we have here is an unseen sample of our data set. This is our data set. So we have the ground truth. We can really compare the predicted mesh with the ground truth mesh, and also do a metric assessment of the accuracy. So the workflow is as follows. We blank out a region, then ask the AI to reconstruct the whole mesh, and then we can compare the input and reconstructed meshes one-to-one. And kind of seems okay. Then we have another example in which we did a similar experiment. Just because, as I said, we have here the ground truth, we can do this metric assessment, and we found out that the accuracy in the reconstruction of the missing regions is quite good, below 2 millimeters. There are failure cases as well, because as you can see here, for example, in this final example, the teeth are missing and the reconstructed area seems quite different from the input, from the ground truth one. And this is because, in the area of the mandible, we had really few training samples. So the data set was highly imbalanced. More interesting is a real clinical use case. Here there's no ground truth because, as I said, there's no eumorphic shape for the given patient. So the workflow is as follows. The input is this. The surgeon will prompt the computer vision system by indicating which is the region that will have to be reconstructed, and this is the output. So it's a good output. According to our surgeons, those that collaborated with us in this project, this seemed to be a reasonable tool that could be deployed effectively, give some benefit with respect to the current workflow. In the current workflow, what the surgeon would have to do is to manually manipulate the preoperative mesh in order to create a eumorphic mesh, which is time-consuming and also, requires some sculpturing skills. So, because Filippo said you have to do bold statements, I would say yes, it kind of works. And this is my final slide. I would just like to say that these are the publications that we got from this project. This, on the right, is a kind of similar task. It's kind of the same task, but on a different data set in which the goal was to automatically design an implant. The eumorphic mesh, patient-specific eumorphic mesh, would be used by the surgeon to plan the intervention and also design an implant if needed. So this is a more implant design-focused data set. And here we just use a more advanced neural network, a different architecture, but in the end the idea is pretty similar. As a final take-home message, at least for us, was that in this, because we are more people that have been doing projects in the other computer vision area. So when bumping into the healthcare space, we immediately found out that there's such a lack of data that make it difficult to apply what we normally apply in other domains. So our follow-up was, now we'll have to work on generating synthetic medical data in a way that is possibly privacy preserving. Because I didn't say, maybe I have 50 seconds, I can say that. We could have a larger data set with the mandibles, but it was a private data set of Sant'Orsola Hospital that we could not release. And this was a problem to publish this work. So in the end, we needed to just rely on the public data set and results were worse. So had we had the chance to release our data set, it would have been better result and more streamlined publication. So now we'll try to create our own synthetic data out of private data set in a way that the individuals cannot be identified and possibly release this dataset. I think is an interesting line of work. Okay, I think I got it on time.